Hi, everybody. We're just going to wait a few more minutes to get started. Thank you. If you just joined, we're just waiting a couple more minutes before we get started. Thanks for your patience. All right. Well, thank you, everybody, for joining this afternoon or this morning, depending upon what part of the country you are in. My name is Scott Weissman. I am a clinical science liaison with Genome Medical. I'm also a certified genetic counselor. And today I'm going to be presenting a webinar on pharmacogenetics, really understanding your genetics and medication response. And just a few housekeeping things. The presentation will last about 35 minutes or so, and then we'll open it up for questions for about 15 to 20 minutes. If you have questions, please, while the presentation is going on or at the end, click the Q&A box at the bottom of your screen to type your question in, and we'll do our best to answer them at the end of the webinar. And again, if you have any technical issues, again, post them in the chat box at the bottom of your screen, and we'll do our best to troubleshoot them. So just a couple of disclosures before we begin. Anything that I mentioned in this talk really should not be taken as medical advice. You really shouldn't stop taking any medications or changing any medications based on anything you hear in this presentation. If you do have questions, though, about things that you hear, I would suggest reaching out to your physician, or as we'll talk about, you are welcome to set up a consultation with a Genome Medical provider at the end. And then something that I want to be upfront about is one of the things that we will not be able to do in this webinar is to address specific questions that you may have about a particular medication. So if you were coming to this with questions about a specific medication, I would encourage you to set up a consultation, but we won't be addressing specific medications in the Q&A part of this. So with that, what the goal of the presentation is to really describe what pharmacogenomics is. This is really kind of, I think, a new area of genetics, and it's new to a lot of people. To really get a good understanding of what pharmacogenetics is, it is good to take a step back and really give an explanation of how the body metabolizes medications and why your genetics play a role into that. And then we'll finish up by talking about different types of pharmacogenetic tests, some of the different medications that can be impacted, and some of the pros and cons of going through this process and this testing. All right, so let's jump in. So essentially, let's start off with what is pharmacogenomics? And really, it's a word that's made up of two other words, where we're talking about pharmacology, which is the study of drugs, and genomics, which is the study of genes and their function. And so pharmacogenomics is really the intersection of these two disciplines, where pharmacogenomics is a way to look at your genetic makeup and understand how it may impact how your body's going to respond to certain medications. And again, for that little bit of background, the next few slides are really going to talk about really how your body breaks down certain drugs, which is called metabolism. And to really understand this, it's kind of important to have a little knowledge of a couple of other terms. So the first term is something that's called pharmacokinetics. And this basically is when you ingest a drug, what your body does to that drug. So you may take a drug orally, it may get inserted through an IV, so it gets absorbed into the body. It then gets distributed throughout the body, typically through blood. And then depending upon the type of drug it is, it may get metabolized or broken down in the liver. And the drug then gets really, again, gets further distributed throughout the body. And then your body eliminates the drug typically through the kidneys and then through urine. So again, pharmacokinetics is what your body does to the drug. And then there's something that's called pharmacodynamics, which is what the drug does to your body. And there's lots of different functions that a drug can do to your body, depending upon what that drug is supposed to do. So it may target a specific organ, or a drug may target a specific protein that your body makes, or a certain receptor on a cell to allow certain things to get into the cell. Way a lot of the body works in a lot of ways that proteins can interact with one another are through signaling pathways. So one protein gets produced, it impacts another protein that then serves another function. It's kind of like a cascade effect. So sometimes drugs can have a certain impact in a certain signaling pathway to, again, help alleviate or treat some sort of medical condition that may be impacted by this signaling pathway. And then again, drugs have the ability to provide a dose response. So certain drugs need to be taken at higher doses versus lower doses to get that desired response for that medication. And so what can happen is, depending upon what your genetic makeup is, sometimes your genetic makeup impacts the ability for the drug to impact your body, making drugs sometimes essentially less effective, or putting people at an increased risk for side effects or adverse reactions than what we would expect otherwise. So as I mentioned, typically when you take a drug, most drugs, if you take them orally, they go down to the stomach where they start to get broken down. And then from there, they get passed to the liver. And the liver is where most of the drugs that you end up taking get metabolized or broken down for your body to use them. And there's really two main categories of drugs. There are drugs or medications that are considered active drugs, where the minute that they really get broken down in the stomach, the drug starts to work. And then by the time that the drug gets funneled to the liver, it gets inactivated so that the drug stops working. And basically kind of the opposite of that are prodrugs, where when you take a prodrug, it's not starting off working, and the drug actually doesn't get activated until that drug is broken down into another chemical in the body once it hits the liver. So ultimately, like I mentioned before, after the drugs are metabolized in the liver, they enter the bloodstream, where they, again, get to the different targets that they need to go, or they impact the different proteins that they need to impact or interact with. And then the drugs get excreted, again, through the liver or kidney, depending upon the type of drug it is, and then ultimately out through the urine in most cases. Now, there is a family of genes that are called the cytochrome P450 genes, or the CYP genes. And these genes account for about 70 to 80% of how drugs get metabolized in your body. So these genes are involved in the formation, which is called synthesis, or the metabolism of various molecules and chemicals within the cell. Now, these genes are primarily active and found in liver cells, which makes sense when you think about metabolism, but they can be located in other cells throughout the body. And they play a role in the development of certain hormones and fats and acids that can be used to digest certain fats. So they, again, play a significant role in not only drug metabolism, but also kind of in the formation of other chemicals that your body needs just through the daily bodily functions that your body does. And the cytochrome P450 family of genes really produce these enzymes that are able to help metabolize external substances in addition to the internal proteins that your body makes. So again, they can metabolize or break down medications that are ingested, as well as internal substances, which again, we just mentioned. And within these cytochrome P450 genes, there are a number of common genetic variations that are involved in how effective your body is, or how effective the enzymes are at serving these functions. So depending upon the gene, as well as the variation which within these cytochrome P450 genes, can really impact how your body metabolizes drugs and whether the body does it too quickly, or in some cases may do it too slowly. And when we're talking about how people metabolize medications, there's a bit of a spectrum in terms of how people can do it, as well as a spectrum of how people are able to metabolize certain medications for certain cytochrome P450 genes. So to better understand the different types of categories there are, kind of what we think about as someone who would have normal metabolism, where you give that individual a drug at the desired dose to remedy a certain medical issue. If you give them the desired dose for their body type, they ingest the drug, it alleviates the symptoms without any problems. Those people would be considered to have normal metabolism, which is technically called an extensive metabolizer. So again, this would be a normal response to a medication. Some people, on the other hand, their body processes certain drugs at a slightly slower rate than normal, possibly leading the drug to have a decreased effect in treating whatever symptom it is, or increasing the risk of potentially having some sort of side effect from that medication. And people that fall into this category are called intermediate metabolizers. So usually by adjusting a dose of a medication up or down slightly, you can get people to having a desired effect from that medication. Oops, sorry, wrong button. But if you kind of keep coming to a situation where the body really is unable to process or processes certain drugs really too slowly compared to what we would normally see, then that drug is likely going to have minimal or no effect in treating a certain condition, again, increasing the risk of somebody having significant side effects. And so we call these individuals who really don't have the ability to break certain drugs down poor metabolizers. Now, kind of going in the other direction, just as much as the body can break something down too slowly, it can also do it too quickly. So people are considered to be rapid metabolizers when their body breaks the drug down a little bit faster than normal. And again, typically adjusting the dose a little bit, you can get somebody to the right dose where the drug can be effective. But then you have people that are considered ultra rapid metabolizers, which means they break the drug down so fast, it really doesn't have the ability to get the desired effect of that drug. And again, can lead to ineffective treatment and also increase the risk of side effects, because if people aren't getting a response, typically a doctor will try a higher and higher dose. And if that dose gets high enough, there is a risk of having an adverse reaction from that. So again, there's kind of one of 5 categories that people typically fall into when it comes to metabolism that can be determined by your genetic makeup with the CYP450 genes, as well as other genes in your body. In addition to your body breaking drugs down, your body also has to be able to clear those drugs and get them out of your system. And so there are a number of genes that are involved in the functionality of clearing drugs. So again, people that have a normal function means that the body is able to remove certain medications from your system as expected, and therefore you will likely kind of, again, get the desired response and not have any risk for any side effects. But your genetic makeup can cause people to be increased clearers, so their body clears the drug faster than would be seen otherwise. And this leads to the drug maybe having minimal to no effect because the body's, again, it's too efficient at getting the drug out of the body. So again, can lead to increased side effects as well as the drug not working effectively. And then you can have the opposite where people either have decreased or poor abilities to clear the drugs out of the body. And when you have that occur, again, the drug can linger in the body for a longer period of time, increasing the risk of having side effects. And with decreased function, you can maybe, again, adjust the dose of the drug up or down to get to that normal clearing effect. But people who have poor function really have a really difficult time clearing the medications. And that may be a situation where you'd want to use a different medication altogether. Okay, so with that background about metabolism and how your body breaks down drugs, a common question that we get is, well, what is the benefit of knowing your pharmacogenetic makeup? And really, based on what you've heard, there's really an opportunity to minimize the risk of somebody having side effects or adverse reactions to certain medications if you know their genetic makeup up front. You can get people to the best medication faster, so you can increase the effectiveness of medications. It can ultimately reduce costs. So again, getting somebody on the right medication up front alleviates the need for trying a medication for a few weeks, determining that it doesn't work, switching to another medication where, again, you have to pay for a second and a third and maybe a fourth medication. And pharmacogenetic testing really takes away the one-size-fits-all prescribing, where typically if you have a specific medical issue, a doctor is going to go to kind of what's commonly used first, and if that doesn't work, start making their way down through a list of drugs. Having that pharmacogenetic information, again, can get somebody to the right drug at a much quicker pace. And pharmacogenetic testing can be done in really two ways. It can be done in a proactive manner where somebody's really healthy, they're not really on any medications, and they choose to undergo pharmacogenetic testing so that if they need a medication in the future, their doctor would then have that information to use for prescribing purposes. Or you can be reactive. So somebody's on a medication or medications and is not responding the way the doctor would think somebody should be. And so they do a pharmacogenetic test to then figure out, okay, is there something with this person's genetic makeup that is allowing this medication not to be effective? So there's pros and cons to both looking at it in a proactive and reactive way. Before we talk about some of the genetic testing that's available for pharmacogenetics, it's just important just to give a little bit of a brief genetics review for those of you that may not be as familiar with this topic. So real quickly, everybody's got 2 copies of every gene, one that you get from mom and one that you get from dad. And the genes are ultimately made up of DNA. And the DNA is made up of 4 chemicals, which are denoted by C, G, T, and A. So it's those chemicals, cytosine, guanine, thymine, and adenine. And again, you may remember that from high school or college biology. And although we all have the same genes, the genetic code of all of our genes are not exactly the same. And those variations in the genes can sometimes be referred to as alleles, meaning somebody's got a gene that has this specific makeup, whereas somebody else has the same gene, but their genetic makeup is slightly different. So we would say, well, this person maybe has the first allele and this other person has the second allele. And so with pharmacogenomics, the information that you get is passed from mom and dad. So knowing which allele you get from mom and which allele you get from dad is very much determining what your pharmacogenetic response is going to be to certain medications. And that gets reported in what's called a diplotype. So again, you need to know what both copies of the gene are in order to know what somebody's metabolizing status is. And when you do the pharmacogenetic testing, when you get the actual genetic test results, so when you look at somebody's diplotype, that is called the genotype. And the genotype indicates what the phenotype is. So in other words, based on your genetic test results, what are you expecting for that person to happen in terms of their drug metabolism? So the genotype impacts the phenotype in terms of an individual's metabolic status or metabolizing status. And to break this down a little bit further, so when a pharmacogenetic test is done, some of the diplotypes are reported in what are called star alleles. And the reason that this terminology is used is that there are many different alleles, so many different genetic variations for the genes that are involved in drug metabolism. They can vary based on ethnic background and other factors. So for some of these genes, there can be, dozens upon dozens to sometimes hundreds of different alleles that can impact metabolism. So typically, when somebody is a normal metabolizer, you would see the result as a star one. Star one being, that's kind of the baseline. That is the normal allele that we would expect to see for that gene. So when you look at test results, sometimes you may see, star 2, star 10, or star 2, star 40. So there are many different possibilities that you could see on a pharmacogenetic test result, and they're interpreted based on what those star alleles are. So again, it really correlates, those star alleles correlate to the functional status of the genes. For other genes involved in pharmacogenetic response, the diplotypes can be reported as single nucleotide polymorphisms, or different genetic markers in a gene from one person to another. So in this example below, for a gene, somebody at a particular spot in the gene may have 2 copies of a guanine, which would lead to normal function. However, in one copy of the allele where you maybe would see a guanine, if you had an adenine or an adenosine, you would get decreased function. And with these single nucleotide polymorphisms, you've perhaps heard about these through like 23andMe and Ancestry.com tests, but really for pharmacogenetic testing, it's not really related to disease risk. It's really, again, looking at the functional status of the genes. And what's a little unique about pharmacogenetic testing is that the testing is really only impactful for the individual. With many genetic tests, you can get a sense of whether or not, your siblings, your children, your parents may be at risk for a certain genetic condition. But with pharmacogenetic testing, because you need to know both parents, because you basically need to know which alleles you've inherited from each parent to know what your pharmacogenetic makeup is, you can't really use the test results to infer what somebody else's family member's genetic makeup may be. So each pharmacogenetic test is specific to the individual in only that individual. When you go through a pharmacogenetic test, here's really an example of what a test result may look like, where you would see the gene that was tested, and you can see here that the first 5 genes are all different cytochrome P450 genes, and the last 2 are other genes that are known to impact your body's metabolism to drugs. Here's the genotype. So again, you can see here's a star 1 for one allele, here's a star 5 for the other allele. For the second one, here's a star 1, a star 3. For the third one, star 17, and so on. And then you would get a phenotype. So for the CYP2B6 gene, this person's genotype means that there are a intermediate to normal metabolizer. Whereas for the CYP2C19 gene, you can see that this person is a ultra rapid metabolizer. These last 2 here are examples of single nucleotide polymorphism results. And you can see here for this particular SNP, having 2 copies of the C allele lead to a normal response. And this person's positive for what's called a 3101 SNP, which can lead to an increased risk for having adverse reactions for drugs impacted by this gene. So again, just an example of what a test result can look like. Some logistics. There are lots of companies out there that offer pharmacogenetic testing. Some companies offer discipline-specific panels, so they may just look at medications that are often used to treat mental health issues, or it may be a set of genes looking to see if somebody is responsive to certain chemotherapies for cancer. Or a company may offer a comprehensive panel, meaning they're going to test for anything related to cardiology, psychiatry, neurology, what have you, and it may cover hundreds of medications. The testing can typically be done via a saliva or a blood specimen, and it can cost anywhere from hundreds to thousands of dollars, and that's really lab dependent. Some laboratories are very cost effective, others not so much. And unfortunately, at this point in time, many insurers are not covering the cost of this testing, except for certain indications, like for cancer treatment, some of these tests may be covered. And part of the reason for this is that in our conversations with insurers, many of them feel that there just isn't enough data or really utility to warrant covering testing at this time. So it is a newer field, and as the data matures, there will probably be more insurance companies that will get on board with covering testing. But right now, it's really probably like a 70-30 split in terms of self-pay versus insurance coverage for this kind of testing. When you get the test results back from a pharmacogenetic company, the labs vary in what they report and how they report it. So some laboratories will provide you with a list of drugs that are can be used, should be avoided, based on the genes that are tested, as well as the results of those genes, so the genotype. Other companies, when you order the test, you actually provide them a list of medical conditions that you have, and then they will provide a more tailored report and recommend specific drugs based on the health issues that you have, drugs that are commonly used to treat those health conditions and your genetic makeup. Some companies will categorize the results based on the metabolism, but not provide the actual test results. So they'll provide drugs that you would expect to see normal metabolism for, certain drugs that should be avoided, but don't give any more information than that. Some will do a tailored report. So you actually not only provide maybe the health conditions, but the medications that you're actually taking, and they'll provide you with a very specific information about the drugs that you're taking, your genetic makeup, and whether they're okay or whether something else should be considered. And then some companies will, when you give them your list of medications, they'll provide information about whether or not the drugs that you're taking themselves could potentially interact with each other, or whether there's certain drug food, drug alcohol interactions that should be avoided, or whether there's what are called drug gene drug interactions, where if you're taking multiple drugs and there's a gene that can impact both of them, how you kind of manage those situations. So if you go back to the first example I showed you in the upper left-hand corner here, so here's a copy of the test results. And then on the right side here, they are giving some specific information related to some drugs. So for instance, in this case, this person's genetic makeup with respect to dilantin would indicate that there's a major gene-drug interaction based on these three specific genes over here on the right, the CYP2C9, HLA-A, and HLA-B. And then there are some actions that can be taken based on the genetic test results. And here's another one just for a reference where Wellbutrin is something where there's really minimal gene-drug interaction, and this would be an okay drug to take. And typically on these reports, they will provide keys for all the different symbols that they're using and what they mean to help with result interpretation. Here's an example of a report where the laboratory doesn't give the genetic test results, but they're categorizing certain opioids that could be used based on an individual's genetic makeup. So they're basically kind of putting footnotes here to say, why certain drugs may not be used or what the interpretation would be. So in this particular case, if you look at the drug fentanyl, they're indicating in number 4 here, which if you come down, they're saying that based on the person's genetic test results, it may impact how the body is going to break this drug down, resulting in reduced efficiency. If you look at codeine, on the other hand, they're giving a lot of information where there's a risk of the individual breaking it down both at too high a level as well as too low of a level, and that the doses may need to be adjusted here. So again, just wanted to show this because it's an example of a lab that does not provide the actual genetic test results. And here's another report. Again, it's looking at certain opioids where, again, you can see the big red X's are telling you these are drugs that you would want to consider alternatives to because this person happens to be an intermediate metabolizer for both of them. And then here's an example of maybe an opioid that would work because they're having normal response to this particular genetic marker here. And one of the key points that I always make when I talk to people about this type of testing is that the pharmacogenetic test results are not the only factor that impact how your body responds to drugs. So as you age, there are certain drugs that we can't get exposed to as children because our body can't break them down. And there are other drugs that, that our body really has difficulty breaking down as we get older. So age can play a role in how your body breaks down medications. Again, we talked a little bit about if you're taking multiple drugs, they can interact with each other and impact the efficacy of each other. Or if you're taking additional over-the-counter medications or supplements, they can interact with certain drugs. There are certain diseases that can impact how your body metabolizes drugs. So if you think about the liver being kind of the primary place in the body where most drugs get metabolized, if somebody has a disease of the liver, that means their liver is not working as efficiently as it should, which means that medications are not going to be broken down as effectively. So that can play a role. And I just mentioned that different foods and different drinks, different like juices, alcohol can also impact how a drug responds or how your body responds to a certain drug. So this is important because it's not unusual for somebody to get a pharmacogenetic test result back where the test result says that, they really are not a good responder to a particular medication, but it turns out they've been taking that medication for years with no problems and it's been working just fine. So the pharmacogenetics is really just one piece of the overall puzzle here. And another important point about pharmacogenetic testing is that it does not cover every single medication that's on the market. So there are certain categories where we have strong evidence and guidelines. So there's certain anesthetics that get used for surgery, antidepressants, anti-seizure medications. I'm not going to go through all these. There are drugs that there's moderate evidence, which basically means that there's kind of data that's emerging to show that there may be some genetic markers that can help with certain medications like beta blockers for cardiac disease or non-steroidal anti-inflammatory medications. And then right now there's just certain drugs where there's just no evidence. Commonly used things like antibiotics and antihistamines, most over-the-counter medications, there really aren't pharmacogenetic markers that we can use to determine whether or not, let's say somebody should take, aspirin versus ibuprofen, something along those lines. There is an organization that is called the Clinical Pharmacogenetics Implementation Consortium. And this is a group of healthcare professionals who are really interested in facilitating the use of pharmacogenetic tests to better patient care. And one of the reasons for that is this is so new that a lot of healthcare providers aren't really aware of this or know how best to use this. So this group called CPIC is basically creating, curating, and freely posting peer-reviewed evidence, evidence-based guidelines to help providers use this information to better prescribe medications for individuals. So as of a couple months ago, they currently have issued guidelines covering 45 drugs involving 20 genes. So if you think about all the medications out there, it's not really a lot, but they are slowly kind of building up this repository as more and more genetic research is being done. This group has been endorsed by a few medical societies with medical professionals saying that, what they're doing is basically valid, it's good work, and they support the work of the CPIC consortium. So here's just a few examples of some guidelines that the CPIC group has put out. And I tried to pick drugs that are commonly used. So there's a drug that's called Plavix or clopidogrel, and it really gets metabolized through the CYP2C19 gene. And for those of you not familiar with this medication, it's an antiplatelet medication that's often given to people that have coronary artery disease, where they're going to be undergoing some sort of percutaneous coronary intervention, like maybe a stent placed, where they're going to give Plavix to help minimize the risk of developing a clot associated with the procedure. However, people that are poor metabolizers with the CYP2C19 gene, which is about 2 to 15% of the population, those folks are at really a high risk of having an adverse cardiovascular event because their body doesn't break the drug down. So before undergoing that coronary intervention, doing a CYP2C19 test would help your doctor figure out whether they should be giving you Plavix or potentially some other medication to minimize the risk of developing a clot. Codeine is another drug that's out there that's commonly used for pain relief. It gets metabolized through a gene that's called CYP2D6. Typically codeine gets converted to morphine in the body. And so people that are ultra rapid metabolizers, which is about 1 to 2% of the population, when they ingest codeine, they get increased production of morphine, which can lead to having toxicity. And on the flip side, people that are poor metabolizers, they get decreased production of morphine, which can lead to insufficient pain relief. So again, if you knew somebody's CYP2D6 metabolic status in terms of their pharmacogenetics, you could figure out whether codeine would be a good drug for them or whether something else should be used. And the last one to provide as an example is a drug called tamoxifen that also gets metabolized strongly through the CYP2D6 gene. This is a drug that's often used to treat estrogen receptor positive breast cancers in premenopausal women and can actually reduce the risk of breast cancer in women that haven't been impacted by breast cancer. And in women that are poor metabolizers, do not process tamoxifen to the active drug in the liver, and therefore it's less effective. And so women that actually have breast cancer may be at a higher risk of developing a recurrence because this drug isn't going to work as well. And so that may tell the oncologist that they want to prescribe a different anti-estrogen type of medication to treat breast cancer. So again, 3 examples that the CPIC organization has put out with respect to guidelines for treating drugs. There's also a couple of other ones that are commonly used. The selective serotonin reuptake inhibitors, or SSRIs, which are typically first-line therapy for depression and anxiety, also have some pharmacogenetic information where for something like Paxil or Zoloft, if you knew somebody's genetic makeup and you knew they weren't going to break the drugs down correctly because they were ultra rapid or poor metabolizers, you could get that individual on a different SSRI or a second-line therapy for depression and anxiety to get that person to an effective treated state faster. The FDA has also put out some recommendations, which are so-called black box warnings with respect to pharmacogenetics. So there's currently 8 medications that the FDA really strongly encourages pharmacogenetic testing because there is a genetic makeup for these drugs that would render them really ineffective. So there's a drug called abacavir that's used for HIV treatment, carbamazepine, which is readily known as Tegretol, which is used for seizures or nerve pain or bipolar disorder, has a black box warning. We talked about clopidogrel and codeine. There's a drug that's called Krystexxa that's used for chronic gout, and a few other ones there that, again, ideally pharmacogenetic testing would be done before prescribing these medications based on this FDA black box warning. So before undergoing any pharmacogenetic testing, we typically encourage people to get genetic counseling so we can spend some time talking about the difference between whether it's a proactive test versus a reactive test. And really where it becomes useful is for somebody that's taking medications and is doing this in more of a reactive fashion, we can have a conversation to talk about whether the drugs that you're taking really have a pharmacogenetic target. Because if not, there really may not be a reason to do this testing if it's not going to give you information that can help your doctors with medication prescribing. We can help identify the best laboratory to use. And our medical team can not only help interpret the genetic results, but we also have pharmacists that can help work with your physicians to help get you to the right medications as well as the right doses. And that allows us to really take a patient-centered approach where it's not just a matter of doing the testing, but we're doing the testing, the interpretation, and helping your medical team, again, treat you in the best manner possible and the most effective manner possible. And as a reminder, as one benefit that you have through your employer, Illumina, if you had an interest in pursuing genetic testing, you can meet with a genetic counselor at no cost to yourself. We can have the consultation, but any pharmacogenetic testing that you would be interested in doing would either be self-pay or we could try insurance billing it. It's not something that Illumina is covering as a covered benefit through this program. If you wanted to schedule a consultation, you can reach out to us at genomedical.com/programs/Illumina to set up a consultation. You can self-schedule, or you can call us and we can set up the appointment for you. So with that, I want to thank you for your time, and we're going to go to questions and answers. Give me 1 second to get to stop sharing here to get to the questions and answers. There we go. Okay. All right. So first question is the genetic material encompassed with the scope of pharmacogenomics limited exclusively to the exome? Do non-coding regions appear to play any role? So that's a really good question. So basically the person's asking is, with respect to your genome, there's areas of your genome that really contain the genes, and there's other areas of your genome that don't contain genes per se, but there's still genetic information there. And so for some of these alleles, most of it is within the exome, but there are a small handful that would be potentially in the intronic regions that could get tested. So again, depending upon the laboratory and your ethnic background, there may be some value in kind of searching out what might be the right lab for the right test, depending upon what the indication was. Let's see here. Second question is, are all drugs affected by pharmacogenetics or only specific types of drugs that are more affected? Again, we talked about that a little bit. It doesn't cover all drugs at this time. It really covers specific drugs. Currently, there are 45 drugs that have specific guidelines, and there's a number of other medications that have a moderate to high level of evidence where pharmacogenetic tests could help with prescribing. Are you aware of any services that include a genetic test providing a readout on susceptibility to becoming addicted to opioids based on a genetic predisposition? So that's a really, really good question. So there really aren't well-established markers to help figure out who's more likely to be more susceptible to being addicted to medications. But there are many pharmacogenetic markers for opioids where potentially the way somebody breaks the opioid down could not be as efficient, leading them to take higher doses, which in essence could lead to addiction. So the answer to that question is kind of the testing can help with that type of information. Additionally, for people that are have had problems with addiction and are really going through recovery and treatment, there are some medications that are used to help those individuals through the recovery process that there are some pharmacogenetic markers for. Meaning, if somebody, for instance, doesn't break down methadone appropriately, that may not be a good medication to help somebody kind of off of heroin. So there are some tests like that out there that can help in that type of situation. Next question is, does 23andMe and other ancestry testings typically offer variants in pharmacogenetic genes? So the answer is yes and no. So if you've done a 23andMe test or an ancestry test, those tests themselves right now do not give pharmacogenetic information. However, if you were to pull the raw data files from those companies, technically speaking, you could get pharmacogenetic information from the raw data file. But because those companies aren't validated to be reporting out the pharmacogenetic information, it's not known whether those results are real or accurate. So we definitely would not rely on the information from the raw data file from 23 or Ancestry or any of those companies to make recommendations. We really would recommend a confirmatory test to ensure that the results are accurate before changing any medications. And just as a side note, 23andMe did get FDA approval to release some pharmacogenetic information, but they haven't started releasing that information yet on their reports. And let's see, the last question I have here is, is Genome Medical in the US, or are we also in other regions of the world? So Genome Medical is able to provide genetic counseling services to anybody that's in the US. Due to different licensing laws in different countries, we wouldn't be able to speak directly to you as an employee if you're in another country, but we could work with your physician. So there could be more of a peer-to-peer consultation, and that physician-to-physician consultation or physician-to-genetic counselor consultation would be covered with the Illumina program. Okay, here's another question. Could I talk a little bit more on pharmacogenetic genes on cancer and cancer drugs? Yeah, absolutely. So there are a few different pharmacogenetic markers that are out there that can help with prescribing. So I talked about tamoxifen during the presentation. Another one that is out there is a gene that is called UGT1A1. And this gene can be very instrumental in breaking down certain chemotherapies that are used to treat colon and other gastrointestinal cancers. Things like 5-FU and leucovorin. That genetic marker can potentially help figure out whether somebody is at an increased risk of having significant side effects from the medication. And the CPIC consortium has put out guidelines with respect to thiopurines for treatment of different leukemias and some other cancers where there is like I said, there's a guideline out there that could be used. So right now there's a few cancers where this can be done, but I wouldn't say it's really across all cancers at this point in time. Okay, another question just came in. How widely are PGX tests adopted in US hospitals for now? There are some hospitals that are in the process of really trying to incorporate this type of testing into certain areas. So for instance, there are some hospitals that are trying to implement pharmacogenetic testing before anybody undergoes a surgery. So to know if somebody's had an adverse reaction for a certain anesthetic, that anesthetic is basically avoided. Other hospitals are trying to implement testing for some of these drugs that have CPIC guidelines, where basically you get a genetic test done, that information gets fed back into the electronic health record, so that when a physician prescribes a certain medication, if you have a contraindication based on your pharmacogenetic reports, an alert is issued to the physician that says, hey, there's a potential contraindication here and another medication should be used. Now, having said that, I would say it's few hospitals that have this. It's definitely not being widely adopted at this point in time. Another question that came in, how much would a PGX cost for someone, let's see this move. Sorry, it's for someone with insurance. If not covered, then what is the average out-of-pocket cost for the counseling and the testing? So hard to say how much your insurance would cover. It really kind of depends upon where you are in the year for your deductible. But most of the laboratories that we use, that we have vetted, that we feel provide a high quality of service, the cost of the testing would be in the neighborhood of about $300 to $400. And the cost of the counseling, again, if you're an Illumina employee, or if you are a spouse of Illumina employee or an offspring, the cost of the counseling is free. There'd be no out-of-pocket expense for that. Okay, another question came in. Can you speak to the role of ethnic and racial diversity in pharmacogenetics? I have heard that pharmacogenetics field has been under scrutiny for wide development of PGX probes for those of Caucasian European descent, but less so for other racial or ethnic backgrounds. So that is very true. Much of the pharmacogenetic data that we have out there is based on testing a large number of people with European descent. There are definitely some different alleles known for people of African American or Asian background. And so again, that's part of the reason that we encourage genetic counseling prior to the testing, because if somebody is not of Caucasian ancestry, we could really have a conversation about kind of what may be the best laboratory, because they include alleles for people of different ethnic backgrounds, or if there is a specific drug that somebody's taken that has guidelines available, are those guidelines really only applying to people of Caucasian background, or can they also apply to people of different ethnic backgrounds? So there's definitely a lot more work that needs to be done for people who are not of Caucasian background in this field. Another question. Can you comment on array-based and sequencing-based PGX testing? For example, accuracy, et cetera. Sure. So there are different modalities that can be used for doing genetic testing. With pharmacogenetics, many of the alleles and genotyping that the laboratories are doing are single base pair changes or small deletions and duplications. However, some of the genes, there are known to be large deletions and duplications that can occur that, again, can have an impact on the body's response to metabolism. So some laboratories are doing just a genotyping platform where they're really only looking at single nucleotide variations, and they would miss the large deletions and duplications. Others use a combination of platforms where they're doing sequencing and an array-based background. And yet others are doing next generation sequencing where they can call the large deletions and duplications and the small single nucleotide variations from the one assay. So again, part of what we've done is we really have vetted a number of these laboratories to know what assays people are using to make sure that we're getting people comprehensive tests. Again, the more comprehensive of a test that you're doing, the higher the accuracy of the results, and as well as a larger variety of alleles that are going to be looked at. And it looks like, let's see, the last question that I have here is, how do we sign up for counseling? So again, you can call our 800 number, which is 877. Sorry, I'm stalling here because I actually don't know the number off the top of my head.
Hi, Scott. I actually have it.
Oh, thank you, Giovanna.
877-688-0992.
Okay. Or you can go to the website, which is genomedical.com/programs/Illumina to set up your own appointment.
And Scott, we actually got one more question that came in via chat from Adalpha. He's asking, does Illumina have a PGX testing product at this time?
To the best of my knowledge, they do not have a standalone product. For individuals who undergo a whole genome sequencing through the UDD program, there is a pharmacogenetic report, but it is only, they only give information back for 12 medications that covers 11 genes. And for those 11 genes, I believe they only look at 35 variants. So it is a very targeted, tailored test. It's definitely not I wouldn't consider it a comprehensive test. Oh, and another question just came in. Do you know which are some of the major PGX test providers? Sure. So like I said, there's a number of laboratories out there. Some of the big laboratories are OneOhm. They offer a test called RightMed Comprehensive, as well as a couple other tests. There's a company called Admira that offers a test called PGX One Plus, as well as they have psychiatric-based tests and oncology-based tests. There's a company called Genelex that has a variety of tests. There's a company called GeneSight that used to have a number of different tests, but they've actually just now pared it down to just a comprehensive test. There's a company called Prescient Medicine. There's a company called Kalos. I mean, there are dozens, and really, there's actually probably 20 or so companies out there that are offering this. It's an area where there's a lot of activity and a lot of people entering this field. Okay. I don't see any other questions coming through. Giovanna, anything else that I need to let everybody know that I forgot about?
Nope, Scott, I don't see anything else on my end.
Okay, wonderful. Oh, something just came through. Will this presentation be available? We are recording it, and I believe we will. Giovanna, please correct me if I'm wrong. It will get posted on the resource center that we have for Illumina. So
Correct.
it will be made available to you guys. We will, I believe we will send it out once it's complete, correct?
Yes, within at least 48 hours.
Okay. Thank you, Giovanna.
No problem.
Okay. Well, again, thank you everybody for attending. We hope you found this interesting, and feel free to reach us directly if you have any additional questions. Enjoy the rest of your day.